Hello, everybody. Thank you so much for having me. My name is David Meyers. I'm an assistant professor of health services policy and practice at the Brown University School of Public Health. And I'm here today to talk about some of the implications that could come with sort of the growth that we've been seeing in alternative payment models, with a particular focus on equity considerations, as well as some gaming that could take place in these types of models. Most of the work that I'm talking about today was supported by either the AHRQ or NIA, at least the work that my group was involved with, and I have no other conflicts of interest to disclose. So I won't go into too much background because we've been hearing about APMs throughout this conference so far, but I think the important pieces are that alternative payment models come in all different shapes and sizes. And while this might have been gone over earlier, there's this really helpful categorization scheme that was first designed by CMS and then an industry group that standardizes across ACMs updated it. And when we think about what APMs might look like, we have category 1, which is fee for service with no link to quality and value. We have category 2, which is fee for service with some quality or value components, something like pay for performance. And then when we start thinking about alternative payment models, we're getting into categories 3, which has some sort of risk sharing, either one-sided or two-sided. And then category 4, which is more population or episode-based payments, things like Medicare Advantage and bundled payment systems. So there's a lot of variation within APM models, but there are certain things that are in common across many of them. I think another important thing that's really important to touch on briefly is also that APMs are not only a thing in traditional Medicare. This is an infographic from the same group, and we find that there's been a growth in sort of the use of APM arrangements or more value-based arrangements across all different types of lines of business. So while the traditional Medicare fee for service is increasing its use of APMs. An even greater number of Medicare Advantage plans use these types of arrangements when they work with providers, but this is also something that's growing in both the commercial and the Medicaid populations. So this is something that's happening across our entire healthcare system, as I think has probably been talked a little bit about today already. So I'm going to talk a lot about the Medicare Advantage program, which I think is kind of interesting in whether it should be considered an alternative payment model or not. As many of you might know, the Medicare Advantage program is the privately run segment of the Medicare program. Private plans are paid on a capitated basis to cover the needs of their enrollees in a year. And in the relationship between CMS and these plans, there are APM type features that are in place. These plans, as I mentioned, are paid on a fully capitated annual basis for their enrollees. And these plans also receive quality bonuses if they score well on their 5-star rating system. Each of these plans then engage with a number of different providers to actually provide the medical services that they offer. And as far as if these arrangements should be considered sort of alternative payment models, there's more variation there. Some plan provider relationships follow traditional Medicare and follow fee for service, but about 30% of Medicare Advantage spend with providers is under some sort of two-sided risk agreement, and about another 28% is under some one-sided risk agreement. So most of the relationships that plans have with providers tend to be value-based and have similar characteristics to other APM models. So I think that there's a lot we can still learn from the Medicare Advantage program about some of the challenges with these types of devices. And I think this is something that you all are probably aware of, but there's a few key features of APMs. And and just to highlight 2 of them. First, alternative payment models have some sort of mechanism for controlling costs, but importantly, they also have some sort of risk adjustment approach to ensure that there's not an adverse selection problem. And 2, APMs also typically have a mechanism for promoting quality, whether it be performance-based payments or minimum quality standards that these systems need to sort of meet. The issue, though, is that these very same tools can lead to a number of the different problems that we might see in APMs, whether it has to do with the way that these tools are gamed or how much that these sort of tools can capture the quality of all beneficiaries that are enrolled in a plan. And that leads me to kind of 2 considerations about APMs as we move forward that I wanted to talk about today. First is the role of APMs in addressing health equity. And second, the potential for this sort of gaming behavior that can come up in alternative payment models. So to get started talking about APMs and health equity, so why do APMs matter for health equity? And I think there was a talk earlier today that touches on this topic as well. But In any aspect of our healthcare system, there's an urgent need to address disparities due to different systematic and structural factors that often stem from different types of racism, and that lead to people having worse outcomes than they should in our healthcare system. And so no matter what side of the healthcare system we're focusing on, there needs to be a focus on equity and a focus on disparities, and APMs are sort of not exempt from that. I think why focusing on equity in APMs is interesting, though, is because APMs, through their additional tools that they have that fee-for-service sort of Medicare doesn't have, they can actually might have more potential to intervene to address equity issues. APMs could be better incentivized through different quality measurement tools to address equity concerns if done well. And so there's a lot of potential here if we can possibly meet it. I think another thing that makes APMs really important is that over time, more and more historically marginalized groups are starting to receive their care from different APM type models. Some of the work that my group has done looking at the Medicare Advantage program, we found that MA enrollees are disproportionately Hispanic, and that the largest growth in Medicare Advantage over time has been among Hispanic, Black, and dual eligible beneficiaries. And in particular, it's also been, the largest growth has been among people who come from geographic areas with the greatest social needs. And so if we want to address equity in our healthcare system writ large, this is an important area and an important venue where we're going to need to come up with ways to encourage the addressing of disparities and to improve equity. And so that begs the question, how are APMs doing so far in these topics? So the answer is mixed. So this is from some work that myself and a group out of St. Louis did that was published in JAMA last year. And we looked at the performance of Medicare Advantage plans on a number of different measures of access and quality. And while we found that overall Medicare Advantage enrollees tended to perform a little bit better in these access and quality measures, when we looked at disparities between white and minority enrollees in these plans, we find that there is sort of no improvement in the disparities within Medicare Advantage. Essentially, the same disparities that might exist in traditional Medicare are just being translated over and are still existing in Medicare Advantage to pretty much the same degree. So look at this a little bit further in some other work that I did that came out earlier this year. We looked at quality rating within the Medicare Advantage program. So as I mentioned before, Medicare Advantage plans are paid on a capitated basis, but they get bonus payments if they're higher rated plans. Particularly if you're a 4- or 5-star rated plan, you get boosts to your payments. And these ratings are calculated on the basis of about 35 different measures of quality and care satisfaction. And so in the study, we essentially went through and we recalculated these star ratings for if only including Black enrollees, only including Hispanic enrollees, and only including low SES enrollees to see, are the star ratings that are currently being used in Medicare Advantage actually capturing the outcomes of all the different beneficiaries who are enrolled in these plans. And what we found is that they don't really seem to be. So just focusing on these bottom two panels here, on the y-axis, we have sort of the disparity in outcomes between sort of Black and white beneficiaries and between Hispanic and white beneficiaries. And what we find, and on the x-axis, we have the overall star rating for a plan. And what we find is actually, as the official star rating of a plan goes up, the disparity in outcomes gets worse. So actually plans that receive bonus payments for being 4 or 5 stars have the largest disparities in outcomes and the largest inequities, in particular for Black, Hispanic, and also for low SES individuals. And so right now, the way that we're currently measuring quality in Medicare Advantage, and this is likely going on in other APMs as well, is not maybe doing enough to incentivize plans to actually address these issues. And this is not only a problem in the Medicare Advantage space. So this is from a JAMA paper that my colleagues in St. Louis and myself also worked on. And looking at the MIPS program, which is the relatively new payment model for people in Medicare who aren't in APMs, found that we found that providers that treat larger numbers of minority patients tend to perform worse in these MIPS performance metrics, which could lead to other issues down the road if the providers that have the most experience in caring for marginalized communities are also getting dinged the most in the way the currently quality ratings are calculated. This is a table from a project that's under review right now that we've put together, looking at the CGR, the Comprehensive Joint Replacement Bundle Program, and looking just at SNF use comparing the differences between the treatment and control group in sort of high area deprivation areas and low area deprivation areas. We find that areas that have higher degrees of social deprivation experience about half the effect of the intervention of beneficiaries who live in wealthier and more resourced areas. And so it's unclear how well the APMs as they're currently set up, how well they're actually reaching everybody who could stand to benefit from them. This is work from a group out of Rochester, and what they found is that the CGR may have actually worsened disparities in access to hip and knee replacement, and particularly among Black beneficiaries. And so it's very clear that we have a long way to go to ensure that these are working for equity. So I think the takeaways from this is that APMs by themselves will not address health equity. There's nothing inherent about the way that an alternative payment model is set up that will automatically address these issues. And in a context in our healthcare system where there are already sort of historical disparities that exist, sort of race-blind and disparity-blind approaches to try and address these disparities won't necessarily cut it. It's likely that these APMs, unless they use more targeted means, are likely just going to keep perpetuating the same issues that already exist in our healthcare system. But there is a lot of potential here. And I think that that's what we need to look at going forward, is that APMs might have the tools to better incentivize health equity if they are able to sort of unlock them and if they're sort of held to doing so. And I think in a positive move here, CMS has actually recently announced that they're starting to look at promoting health equity through their different CMMI models and also in the Medicare Advantage program through their STAR rating system. So I think that there's a lot of potential here. The second consideration that I wanted to talk about is about potential gaming that can happen in these systems. So as I mentioned before, in most APM models and the Medicare Advantage program, payments are typically risk adjusted because you want to sort of pay adequately for treating higher need patients. The issue though is that this can potentially create an incentive to maximize the recorded risk that's recorded for these beneficiaries in a behavior that's often called upcoding. Another potential issue is around quality metrics. These quality metrics in APMs are important to determine who sort of gets bonus payments, who gets their full payments. But there's also incentives to then be selective about maybe who these quality metrics are actually capturing that can limit the performance of these APMs and limit them from really reaching their potential. So this is from a paper that we did looking at this tool called chart reviews, where basically Medicare Advantage plans have the ability to add more diagnosis codes to their beneficiaries that their providers that the patient saw might not have actually included in their initial visit. And what we found is that the use of these chart reviews can lead to billions in additional payments for plans. And similar findings have been found in other studies. So there's a great set of work by Jacobs and Kronig looking at coding intensity in Medicare Advantage. And after sort of standardizing and looking at patients who, based on other metrics, appear to be about as sick as each other, Medicare Advantage beneficiaries tend to accumulate many more diagnosis codes, and as a result are paid at a much higher rate than maybe they should be if we were to standardize them across against other beneficiaries. And as I mentioned before, this is also an issue on the quality side. So this is some work from some of my colleagues that looked at the reporting of readmission rates in Medicare Advantage data. And they looked at sort of this plan reported readmission rate data that's used for quality performance metric and compared it to sort of a claims gold standard. And what they found is that plans tended to not report beneficiaries who were more likely to be readmitted when submitting their quality data. And so the people who were actually included in the quality metrics tended to be those who had better outcomes than those who were not included in the quality metrics. And this, while it's happening in sort of the readmissions context, can happen across a lot of different types of quality variables, and is something that's important to think about who's actually being considered in sort of the variable calculation. And I think related to that, it's also important to note that this isn't always intentional. So this is some work that we have forthcoming looking at CAHPS responses for people with dementia, and CAHPS is used to measure the quality of Medicare Advantage plans and sort of their STAR ratings. And what we found sort of in this bottom row here is that beneficiaries with ADRD were about half as likely to be included in performance measurement as beneficiaries without ADRD. And a lot of this is because of beneficiaries with ADRD tended to be in more institutional settings and had lower response rates. But as a result, the quality metrics that are used they're used currently to evaluate Medicare Advantage plans might not currently be reporting information on sort of everybody who is actually receiving care in these plans. And so moving forward, it'll be important to think about ways that we can guardrail this quality measurement, either through more auditing, more automatic adjustments, and other sort of approaches moving forward. So just a couple final thoughts about sort of APMs. I think it's clear that alternative payment models have enormous potential. But I think as we move forward, it requires more care and attention. APMs are the future of our healthcare system, but they also create opportunities for gaming, and they don't inherently address health equity. And I think that as we move forward and we think about how we're going to continue to design these systems, it's essential that we give careful consideration to make sure that we're actually maximizing these benefits, that we're actually providing equitable care for everybody involved, and sort of minimizing sort of the bad behavior that can happen in these types of models. So thank you so much for taking the time, and I look forward to the questions and discussions. So thank you so much.